Dr. Giorgio Iatrakis will make his presentation with high-risk lesions. Please, Professor.
Thank you. I'm just waiting the fourth one, yes. Okay. So good morning again. Thank you for the invitation. And we'll speak about high-risk lesions, LCIS, ADH, and ALH, and their management. It's better this one? Okay. So, I don't know if it's correct, but that's the terminology. Benign lesions of the breast are categorized in these three categories, as you see. And we'll speak about proliferative with changes with atypia. So include atypical ductal hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. How we can categorize lobular carcinoma in situ in benign lesions, it's another question, but that's the true for the today vocabulary we use in breast cancer, in breast medicine. So, what are the main, let's say, guidelines about these three entities? Is careful surveillance and consideration of risk reduction strategies. That means avoid some things like obesity and things like that, and maybe counsel the woman to take some drugs depending on her age. First of all, we must have a correct diagnosis. Atypical hyperplasia includes atypical ductal hyperplasia and typical lobular hyperplasia. The first one is more dangerous than the second one. This one is more dangerous than the second one. We can diagnose it after mammographic microcalcifications, and of course, as a first step, core needle biopsy. Let's say that in core needle biopsy, we have such a diagnosis, atypical ductal hyperplasia, which is the next step. The next step is that we need a real surgery. I need to remove the whole lesion, because in percentage which is more than 20%, we'll conclude finally that it wasn't only an atypical ductal hyperplasia, but it was an invasive cancer. In terms of pathology, it consists of uniform epithelial cells, etc. Actually, it's resembling very, very much to DCIS, but it's a smaller lesion than DCIS, but otherwise it has a great resemblance with DCIS. Yes, it says that. Shares cytologic features with low-grade DCIS. That I said before, after diagnosis of ADH by core needle biopsy, we need an excisional biopsy because we'll discover in more than 20% after this surgical step that it wasn't just ADH, but it was an invasive cancer. So let's say that our first step wasn't a core biopsy, but it was an excisional biopsy. What is the next step after diagnosis of ADH after an excisional biopsy? Here the things are simple. We don't do nothing. I mean, we have diagnosis, we counsel the woman, and that's it. Re-excision is not indicated even when margins are positive for ADH. That's the guidelines for several organizations, I mean, NCCN, etc. Okay, finished about that. We'll come back about some drugs the woman could take for the whole life and go to a typical lobar hyperplasia. This is a more innocent, let's say, lesion, because if we have this information in core biopsy, we don't do anything else. I mean, it's enough. Okay, not very interesting. As the terminology says, it's about the lobule, the other was about the duct. As a typical ductal hyperplasia sharing some features with DCIS, a typical lobar hyperplasia shares some features with low-grade LCIS. So, that I said before, after diagnosis of ALH by coordinate biopsy, excisional biopsy should not be performed. Why? Because here the upgrade is much more less than in the case of ADH. We said that in the case of ADH we have more than 20% in excisional biopsy to find an invasive cancer. Here this percentage is much less, it's less than 3%. So we don't need an excisional biopsy. You know, it's a game of possibilities always. Huh? Does not require excision. This diagnosis is already in surgical excision, no additional surgery. It's something that we can conclude without read this slide. But we must inform the woman that after such two diagnoses, there is a relative risk of subsequent breast cancer in her lifetime, which is 3 to 5. That means 3 more times than the general population to have breast cancer in the future. And this risk is not only for the ipsilateral breast, but it's for the other breast as well. The cumulative incidence of breast cancer over 30 years is almost 25%. That means that if we have that diagnosis at the age of 30, when the woman will be 60 years old, has a great chance to have cancer, which is 35%, which is much more than 1 in 8 for the general population. We are not sure about that, but in the past we thought that if the woman has a family history with breast cancer, these percentages are much higher. We don't believe that anymore. We are not sure what happens because, as you know, if you have a family history of breast cancer, you already have an increased chance to have breast cancer in the future. Okay, not compare older and new data. It's a little boring. So, let's say that we have a woman with such a diagnosis. What is the next step? The next step is chemoprevention. What that means that if we have a woman, a postmenopausal woman, depending on her bones, depending on her risk of thromboembolic disease, depending if she has a uterus or not, we can choose what will be the future drugs for that woman. Let's simplify the things. Let's say that we have a woman with such a diagnosis in the age of 60. Okay. This woman is interested about to prevent breast cancer in the future. Is the only thing she cares. So, for that woman, there is one solution, tamoxifen, only that solution. But if that woman has a history of thromboembolic disease or risk factor for thromboembolic disease, or she concerns more about what happens with my uterus. I heard or I saw on the internet that tamoxifen increases my chance for endometrial cancer. Oh, sorry, in that case, you cannot take tamoxifen. If your priority is not the prevention of breast cancer, but your prevention is to not have as a complication of the drug endometrial cancer, in that case, tamoxifen is not good enough for you, then you should take raloxifene, which is good for your bones too. Yes, doctor, but I heard that raloxifene is not good enough for my prevention in terms of breast cancer. Oh, sorry, my lady, but FDA approved only tamoxifen and raloxifene for this case. And the woman insists, forget FDA. I want to have the most protection for my breast, irrespectively of the rules of FDA. Is there another proposition? Yes, in that case, if you don't have problems with osteoporosis and things like that, the best solution is an aromatase inhibitor. And not every aromatase inhibitor. I mean that letrozole is not included in this game. It's only exemestane and anastrozole. And exemestane gave some better results than anastrozole. So, as a conclusion, for postmenopausal women, the best choice for prevent a breast cancer in the future after such diagnosis is to give an aromatase inhibitor if there is no risk about osteoporosis and things like that. And it's a little dangerous to say that, but according to data and according to statistics, exemestane looks a little better than anastrozole. Of course, surveillance. What that means, surveillance means a clinical examination every 6 months, mammography every year. Although, as you know, that in the general population, some organizations, I mean, as in Canada, etc., removed the auto exam of the woman for trying to find the things in her breasts, and removed also the clinical examination from the doctor. Actually, they don't cancel the women for breast self-examination or clinical examination from the doctor. But anyway, at least mammogram once a year. So this is more serious. You can see that in the terminology, carcinoma. It's not hyperplasia anymore. High risk for invasive breast cancer. It's not very common. It does not give some classic pictures in the mammography. Another question about all these things is, apart of clinical examination, if you believe it, apart for mammography, which you should do every year, is something else we should do? I mean, like MRI. The answer is no, because, as you know, MRI is much more sensitive than mammography, but on the other hand, here its specificity it's much lower than mammography, and thus doing MRI in these populations you will have breast biopsies with benign results, and furthermore, in related studies, MRI did not prove that you increase survival or whatever. Another significant point about the drugs I talked before is if the woman will ask you, doctor, please tell me, taking these drugs or doing this examination, my life will be increased. I mean, I live longer than a woman that forgets that she has all these things, hyperplasia or LCIS. My friend has the same problem like me, but she doesn't take nothing. If I take the drugs that you said, my life will be increased, I'll live longer. Unfortunately, the answer is no. So why doing the exams? Why taking the drugs? The answer is that if you have problem with cancer, you must treat the cancer. Treat the cancer means surgery. Treat the cancer means radiotherapy. Treat the cancer means lower quality of life. That's why you are doing this. That's your explanation. You should say to your patient, not increase your life. The mean age of diagnosis of LCIS is more than 45 years. More than 88% could be identified as menopausal women. I mean, it's an entity mainly in reproductive age women. And most of these findings are hormonal positive, very rarely HER2 positive. Almost in all cases, HER2 is negative. As I said before, not detected mammographically. Very often an incidental finding. Not very interesting thing, but the more interesting about that actually there are two categories of LCIS. The classic one, which is more innocent, let's say, and the most dangerous, which is the non-classic one, the LCIS. I mean, the non-classic form with a broader spectrum of appearance is much more connected with breast cancer in the future. As I said before, so the dangerous thing about the LCIS is this one, pleomorphic LCIS with necrosis and things like that. It was first described recently. Central necrosis and calcifications are the pathologic findings that we'll describe in the pathology report. It's important to recognize that it's not a simple LCIS, but it's an LCIS with necrosis, because the differentiation from high-grade LCIS is not very easy. And the most interesting is that this entity is much more connected to the breast cancer in the future than the classic LCIS. Management. If we have classic LCIS, like atypia, as I said before, in clear surgery, we don't do anything else. But if we have LCIS with necrosis, pleomorphic, and the margins are not clear, we must reoperate to have clear margins. So the question is, what exactly do you mean? What do you mean clear margins? 1 millimeter, half millimeter, 10 millimeters, what do you mean? Because in DCIS, there is a gold rule, 2 millimeters. Here, unfortunately, there's no rule. Clear margins. Do what you think, what you believe. Okay? I don't think that you need to read this slide to conclude that. If we had this diagnosis in core biopsy, we must be sure, and then we're doing an excisional biopsy, of course. not the classic one, the LCIS pleomorphic with necrosis, as I said before, which is much more connected with invasive breast cancer. Surgical margins should be negative in LCIS pleomorphic. If not, re-excision. But how much re-excision, we don't know. Re-excision, clear margins, without any rules. There are no data and related guidelines to the optimal width of negative margins in pleomorphic or florid LCIS. Okay, there's a problem. We don't believe to bilateral mastectomy anymore. I asked a few minutes ago Professor Voiculescu about that because his speech is about prophylactic mastectomy. It was, let's say, a rule of the past. We don't believe, we conclude that it's much more drastic than what we really need in LCIS. I mean, drug therapy and surveillance proved to be enough. And there are some other things about this kind of therapy today. And say that the 10 and 20-year breast cancer specific survival for women with LCIS is excellent. 98% in 10 years and 96% in 20 years. So it's very, very drastic to do bilateral mastectomy in a woman with such a good future. Furthermore, whatever you do, bilateral mastectomy, lumpectomy, whatever you do, does not no effect on survival, which we said is very, very high. And there's no features in pathology, I mean features to see maybe in this woman, because the pathology says that I must do bilateral mastectomy. In the other woman, the LCIS, but with other characteristics, not doing bilateral, there are no such things. We said that we have these two big categories, classic LCIS and pleomorphic LCIS, but it's not enough to categorize further the women who will do bilateral mastectomy and who not. We said that before about family history, etc., etc. We are not sure about that today. Black women, etc. But even in black women, we don't cancel for bilateral mastectomy. Active surveillance and chemoprevention. I already said without slides. I have slides about the chemoprevention, but I already said about that. I don't know if I'm okay in time. 4 minutes more, I think. So, okay, I finished. I finished. If you have any questions at the end. Okay, thank you very much.
Thank you, Professor. Now it's my pleasure to introduce Professor Yarabas and next speech about genetic counseling for healthy women, the indication, tools, and interpretation of these genetic tests.
Thank you very much. Good morning, everyone. My topic is genetic counseling for a healthy woman, indications, tools, and interpretation. I would like to challenge the word healthy in my talk as apparently healthy, and I will give clues for rethinking the apparently healthy woman in the era of new diagnostic techniques, which are of importance in implementing in our future practices, like polygenic risk scoring, ctDNA testing, multi-cancer early detection signaling, and AI implementing, especially radiological techniques. But before I would like to give my core thesis, we all give counseling with guideline-based or guideline-directed approach in these days. Because especially the NCCN guideline gives us whom to test, when to test, what to test. But my thesis in this talk is that guidelines tell us when to test. Risk intelligence tells us how to interpret, most importantly, how to personalize, and how to follow. So the future practice is moving from a BRCA testing or germline or genetic testing eligibility to a risk architecture. Why apparently healthy is more precise for me? Because absence of active cancer does not necessarily mean absence of risk. There might be inherited and familial risk, and this might be invisible clinically. PRS may reveal hidden high risk without family history. The lesions of the breast can be part of a risk phenotype, as we all saw in the previous talk. And of course, cured survivors are not risk neutral. I will talk about them in my talk. So apparently healthy women is not only one population. It will have 6 counseling scenarios. And in these scenarios, we will have a risk intelligence pathway with 4-axis counseling model. People might have family history or might not have family history. They might have benign lesions in their breast or might have premalign or high-risk phenotypes of their breasts. They might be cured survivors, or they might come to your office, to your clinicians, with some tests that they have obtained with direct-to-consumer testing methods, and they will ask in panic mood that, am I at high risk, what shall I do? So the vision should be like this. Each scenario has different tool set and interpretation logic. I have talked about the 4-axis counseling model, the family history axis, the breast pathology or phenotype axis, the personal cancer status axis, and of course the molecular layer axis. It will of course include the genetic testing, the genetic background of these people, including the polygenic risk scores, and ctDNA test results and multi-cancer early detection signals, as well as AI implemented, especially radiology. Let's start with the guideline. NCCN, of course, remains essential as the backbone of our practice. It gives the testing threshold, it gives the gene list, and it is up to date always. It gives clues for the syndrome management, and it gives us the standards of safety. So it could be an entry point, not an end point. So we should start with guidelines, but this is not where we stop. For example, it's not the complete interpretation engine. PRS, AI, MCED, and ctDNA interpretation not yet included in guidelines because we have not enough evidence how to manage these tests. And so we should share decision making as a teamwork. These are the tools. I have not enough time to one by one talk about those. They are all talk topics, and I'm sure especially Christop's talk will complement my session. For example, the NCCN. It gives, is testing indicated or not? We have some risk modeling options. They are online. I'm sometimes using the Kuzik model. There is a, for example, example of its output. The models give some probability scores if the person will be carrying a BRCA mutation or a pathogenic variant carrier is at risk. Is there a future absolute risk, increased risk, a 5-year risk profile, or the Cusick model integrates breast density, benign disease status, and family risk, and gives a probability model for us. What does polygenic risk score do? We all born with our inherited DNA. We inherit them from our parents, and of course we carry many variants, which might be polymorphic. I mean, they are common in populations, but especially with those integrating with DNA repair mechanisms, for example, gather together and give a polygenic risk background. ctDNA testing gives molecular signal for molecular residual disease or molecular relapse. Multi-cancer early detection testing gives a signal with only blood testing. And AI is of course important, but how do we integrate this complexity into a structured clinical interpretation is important. So the core skill is to match the tool to the clinical question. The risk model map gives an output, but it is not the clinical decision. It's the structured basis for discussion. Germline testing is, of course, maybe the most evident part of this counseling model, but we have some take-home messages. For example, BRCA, of course, remains essential, but not sufficient anymore. We have more genes to be tested, and they have place in the guidelines, like P53, Cadherin, and ATM, and others. A negative panel test doesn't mean average risk. And most importantly, the most challenging for, of course, us and for the clinician, a variant of unknown significance is not a positive result, of course, but sometimes the clinician finds the people with unknown significant variants dangerous. We say that it shouldn't be used for the basis for surgery, and sometimes cascade testing, testing for family members will be essential. And as we test more and more genes, the interpretation burden, of course, increases, especially with this loose phenotyping. Polygenic risk score is a bridge from monogenic to polygenic risk, of course. In germline testing, for example, in BRCA testing, it's the traditional germline testing, of course. We focus on single genes. We search for pathogenic variants, we search for mutations, and these we search for the genes, high impact genes with high effects. But if the panel negative, but sometimes we think that we know that the risk remains, polygenic risk scoring might be helpful. It measures the cumulative contribution of many common variants with small effects. So those variants are not of importance one by one, but collectively they might be capable of risk modification. So it's not a replacement for clinical genetics, but it's a new layer in risk interpretation. And it might be useful in two situations. First, in women without family history, where traditional tools may miss hidden high risk. And second, in women with negative panel testing, but persistent clinical risk. Family history is very important. It's one of the core goals of our medical education system. We want all the medical students know how to take a family history and draw simple pedigrees, for example, and interpret the pedigree pattern and interpret the risks of families. But no family history doesn't mean no risk, because there might be small families, we might not know the paternal lineage, there might be missing histories, there might be early deaths, there might be few female relatives, and males are, lucky for breast cancer. And some procedures might be masking some women of the family's risks. There might be some low moderate penetrance variants like polygenic load, polygenic risk scores, and there might be breast phenotype risks underlying the family history. So it's of course a risk measurement, but it is not perfect. So when PRS, the other methodologies are in common, it may become the important part of the practice. Coming to the benign lesions, we saw that they are not only benign. In some women, benign pathology may be the first visible point of a future breast cancer risk phenotype. So we should integrate all these models when interpreting the healthy woman with benign lesions. People are apparently healthy when they might be survivors of previous cancers. They might have previous cancer history. So we are seeking for the second primary or contralateral risk, and these need reinterpretation. So we usually the clinician, the surgeon, you ask the patient, the people, if she had been tested before, and the answer is mostly yes, because the spectrum of genetic testing continuously increases as we follow the guidelines. And they say, yes, I have been tested and it was normal. We should ask that, can I see it? Because the testing may be not in enough spectrum. It might be a BRCA only. It might only reveal single nucleotide variants, not copy number variants. Or it might be an old test. So a reinterpretation might be mandatory. And sometimes testing the family members will be important because there might be some variants of unknown significance in the test result. And of course, the survivors are sometimes in the clinical manner being treated, followed up with ctDNA testing for minimal residual diseases, but this should be of cautious survivorship topic. So the goal is not only explaining the old tumor, it's managing the future risk. It's a prospective future. Liquid biopsy is a powerful technology if used with correct boundaries. Today, it's not routine in breast screening for healthy women, of course, but in oncology, we are using it in profiling, in response monitoring, in MRD and relapse research. But in survivors, molecular signal versus molecular silence is an, of course, emerging concept. But there are dilemmas here. For example, if ctDNA is positive, but we have no proof of active cancer, what will we do if imaging is negative? So avoiding overaction is important, and giving the correct counseling is important. But it's obvious that tomorrow's follow-up may be molecular, not only radiologic. Multi-cancer early detection is again a liquid biopsy technique. It gives signals. We use the methylation patterns of the ctDNA. We first try to obtain ctDNA, and we use the methylation patterns. And some tests also use fragmentomic methodology. So we try to detect cancer signals from blood. And sometimes it gives the tissue of origin prediction. So a positive test requires diagnostic pathway. It's a triage opener. Do not need to panic if this test is positive. If it gives the tissue of origin, we shouldn't forget that it's only a hypothesis, not a guaranteed primary site. If the test is negative, it's not a reason to stop established screening, of course. And in the future, it might fit into the risk-adaptive screening. So it shouldn't now replace the established breast, colorectal, cervical, or other screening programs, because this signal is not a diagnosis. And the negative result is not a cancer-free certificate. AI, people always ask us, will AI be a replacement for you doctors? But it's not a replacement in any layer. it's an integration layer of our practice. We should use this like that. For example, we are using AI in implementing family history to pedigree analysis and risk patterning, and we are implementing it with NCCN guideline matching. If we use it when after testing, we use it for the prioritization of genetic variants and interpretation of the genetic variants. We use the risk scoring AI implementation for population calibration, for example, and radiologists now use AI integration. And of course, we use AI for interpreting the multi-cancer early detection signals. So the clinician should give it the meaning. Coming to the end of my talk, I will have 4 take-home message slides. First of all, to avoid slides, interpretation traps. Negative BRCA is low risk? No. The scope of test is important, family history is important, and other testing methodologies, and of course, BRCA phenotype is important. Is detecting a variant of unknown significance make the test result positive? No, it's not to be used for clinical action. Is high polygenic risk score means equal to the diagnosis of a hereditary syndrome? No, it's only a risk modifier. Is negative MCED means the patient is the woman is cancer free? Of course not. Established screening should continue, and AI output is not always the truth. We should use it as a support tool. It mustn't be the authority above us. So for the future prospects, the precision prevention concept will be adapted to our clinics, implementing all the tools, all the modern tools, and this will become not the clinics will become, the clinician will become from, evolve from a test ordering person or test ordering unit to a interpretation and prevention architect. The counseling language is of course important. The genetic counseling shouldn't be only a genetic counselor's or a medical geneticist's job. A clinician should know how to talk, and sometimes counseling with, about cancer is like a psychotherapy session, of course. A negative panel can be recommended as this does not erase risk. It means no pathogenic variant was found within the tested scope. High PRS could be implemented like this to the patient. This is not a diagnosis. It's a genetic tendency that modifies the absolute risk. The negative MCED can be told like this. This is not a reason to stop recommended screening. And of course, we will not use this variant for clinical decisions at this time. Finally, I should say that apparently healthy women are not one population. Genetic counseling is becoming risk orchestration with all these models. And the future is not more testing. It is better interpretation. The clinician who separates actionable risk from uncertainty will create value. Thank you very much.
Thank you very much. As you know, we have questions at the end of the session. Now, it is my really great pleasure and privilege to present a very, very good friend of mine, who not only was the first of his class in the university of the year, but he is one of the experts. I sent my specialists, my young specialists, my older specialists to him to learn how to do ultrasound, to do core biopsy, and to generally address cancer, and every kind of breast pathology. This is Professor Stefan Voiculescu. The subject you might know about Angelina Jolie, but this is not only her who put on the screen the bilateral mastectomy. So Professor Voiculescu will tell us something about that. Thank you.
Thank you very much for this introduction I don't deserve. And I shall speak something about, you know, if I had this theme 10 years ago, it was very simple, 5 minutes and all is clear. Now, we shall start with what means healthy. Healthy is not enough observed and researched by all clinically means, usually. Speaking about high risk, this is also something that we must make cutoffs. High risk is about more than 30% risk of having something. And if we apply this at 2 million cases of breast cancer per year, we shall make a division of high-risk patients, and this may be starting with genetic syndromes. 5, maybe 10% of the patients may be in this situation. This is associating germline mutations. I am very glad that I am speaking about the very clear presentation of Dr. Yararbash, and this is my task very much. You know, BRCA is about 4% triple negative cancers becoming 15%. So this is the very important thing. Young patients, younger than usual, with more aggressive tumors, and this is 5 times more prevalent, this kind of aggression. Also, we have some less dangerous mutation in other genes with high penetration or moderate penetrations. You have this the list. It's no need to read them. Also, some other things, less chest irradiation before the age of 30, atypical dysplasias or in situ carcinomas, plus the family history of breast cancer. So this is high risk. It's important because if we are considering the BRCA patients, this is, as I told, much more frequent triple negative tumor in younger patients outside the screening. This is less visible, and you have some examples, and if you are seeing here, it may look like a fibroadenoma, even with a vessel that is marginal. Here also, only in these cases you may have some suspicion. Also, in usually it's the kind of BIRATS3 lesion. So this is important. To Professor Tika told you BIRATS3 in a patient with high risk, you may take a biopsy. Also, these cases are lately found because of this, are more aggressive because rapidly growing, and we are limited by our therapeutic armamentarium. The genetic mutations are important because they have the lifetime cumulative cancer risk of up to 85% for BRCA1, for example, for the best primary, but also we can have a second breast cancer or a contralateral breast cancer, and you see the ciphers. It's not only for the breast, it's also for the ovary, for the prostate and pancreas, but okay, we are speaking breast. It's affecting 1 in 400 patients. So if this theater will be full, maybe we have one BRCA mutation here. Hopefully it's not full. We may, I don't speak about the personal cancer events as motive to test for the BRCA, because we are speaking about healthy patients, but family cancer events must be explained. 2 breast cancers in first degree relatives and 3 in first and second degree. 1 breast cancer in first and second degree if under the age of 35 or bilateral. 1 case of breast cancer in a man of being a sibling of first or second degree, or if it's Ashkenazi population. 1 case of breast or plus ovarian cancer in the same sibling, the first degree. 2 ovarian cancers under the age of 50, and also 1 first degree carrier of BRCA mutation. This gives the risk of 50% having this mutation also. The mutation detection may be obtained from blood and saliva. Forget tumor, we are speaking about healthy patients, and it's very difficult to obtain some tumoral tissue from them. The methods, it's direct or next generation sequencing or multiplex amplification. Does positive result deny the breast conservative surgery? It's a question that it's before her time, so we shall answer after that. The prophylaxis in high-risk genetic is a bilateral reduction mammectomy. And can we replace this with something? Maybe. Bilateral salpingo-oophorectomy was advanced, but it's not for the breast cancer, it's for the ovarian cancer. Antiestrogenic therapy, SERM, tamoxifen, raloxifene only in postmenopausal. I learned that not letrozole, but anastrozole and examestan. Oral contraceptives may lower the ovarian risk, but in the same time they may rise the risk of breast cancer. And special screening, it depends if we are offering MRI or mammography and ultrasound each 6 months. We come to Hamlet's dilemma, and this Hamlet has the breast of you will see who. And the dilemma is, why should I cut off both of my nice breasts being a healthy woman? Because facing more than 30% degree risk for breast cancer, this is Saint Agatha, and I explained for Muslims that this is a Christian saint that has the martyrdom of having cut both breasts. But I suppose that she were here before the genetic testing. It was not the era. But if it's BRCA positive, St. Agatha will consider that bilateral mammectomy seems to be a reasonable recommendation, and this is especially after 2013, Angelina Jolie told about her experience of losing breast. And this is for not having to answer what to do when your get up and go has got up and gone. The epidemiology, breast risk reduction mammectomy, bilateral risk reduction mammectomy prevalence is rising, not in the same way, much more in United States than in Asia. And for a population of more than 25% risk, it was 6.2%. But the uptake of bilateral risk reduction mammectomy depends on something. If it's a BRCA mutation, almost half of the patient will choose this mammectomy. What happens with the same risk for a non-BRCA mutation? Look, it's 9%, and it's more than 5-fold difference. And this is Angelina Jolie. And this may reach about 3% of patients with less than 30% risk of breast cancer. The survival has some benefit if we are proceeding to this prophylactic mammectomy, but it's not significant. It's about 3% in 10 years. So compared to the importance of this mutilation, the same survival is for observation and bilateral prophylactic salpingo-oophorectomy, or bilateral risk reduction mammectomy plus. So it's the same thing if we are associating the ovarian suppression. Then why? Because it's much more peace of mind offering to have escape from the breast cancer-related anxiety and the stressful screening. Is mammectomy safe enough? We have some residual breast parenchyma, then maybe up to 5%, so this is important. We have not zero risk. The residual tissue depends on surgery experience and workload, the type of mastectomy and the breast site, and more often we shall find this in the nipple areola, behind nipple areola, in the lower outer quadrant, in remote skin flaps, or in Spence tail. I skip the contralateral mastectomy, but I want to show you something. This applies also to bilateral. The complications for the affected breast are the same for unaffected breast. So imagine what's happening to remove something healthy and to have some severe complications. This must be taken into account. The bilateral mastectomy is followed by immediate reconstruction. By default, it's almost 100%, and it's almost always prepectoral. It shifted skin to nipple-sparing mastectomy, and the recommendation are some important mutations, thoracic irradiation, multiple siblings with breast and ovarian cancer, high individual risk patients demand also. The efficacy, this is important because you see that it's important at what age you are performing this, and it's very important you have these trials. It's very important to see that if it's in the 30s, it's much more effective, important, and beneficial than if it's in the 50s, because we have a spectrum of risk, and a patient with BRCA mutation of 50 years old that didn't have a breast cancer till that age will not have the 87% risk of breast cancer. So this is speaking about, I shall think about the last trial. 10-year delays is giving a 10-fold reduction of benefit in both BRCA mutations. If we are doing this, it's important that we shall obtain symmetry and stability of the results, and to whom I already have explained the motives to ask for this are having one first-degree sibling, having his own cancer, it's not applying. Having the mutations in first-degree siblings, being young, married, and having children, so the social status is important, and also cancerophobia. For this operation is pleading the reduction of breast cancer, that is important. Much more important, the unknown cancer that are cured, and this may be up to 3% of cases, occult or ignored cancers that are discovered doing this prophylactic and stupid operation, apparently. And this is also giving some release for the patient against mastectomy. Breast cancer is still possible in 2, 3, or maybe 5% of cases. The surgery is tedious, longer recovery, higher morbidity, and may be iterative. This must be told to the patients. If you are doing a plastic surgery, it may be not the last operation you have. So also surgery must be very expensive also. Can we preserve? Maybe yes, because even in BRCA mutation it's possible. We have the overall survival the same as for radical operation, the same local control, but we have higher contralateral and ipsilateral second cancers, and if the genetic risk is moderate, breast conserving surgery is a very reasonable option. But, however, think mammectomy for ATM and TP53 mutations because of the risk of radio-induced angiosarcoma. This is important to be known. And sure, we have some motives to preserve the breast. But I shall end speaking that it's highly advisable to see the entire picture before buying it. This is the entire picture. And the patients will thank you for minding all and informing all these aspects. And also I'm inviting you at Censo conference in 1st to 3 April next year. Thank you.
Thank you, Stefan. The question will be at the end. Thank you very much for respecting the time. We are a bit late.
The next presentation sounds like an oxymoron, screening in high-risk healthy women, but as Professor Stefan defined high risk, please, Krisa Giacouri. Yeah.
Good morning to everybody. I thank the organizers for the invitation, and I am happy to be here, and I feel honored to be in a surgical meeting for breast surgeons as a radiologist. My talk is about screening in high-risk healthy women, and actually I will concentrate to the risk-adapted imaging beyond average risk screening. Where is the... So, the screening, we are moving, in these cases, we are moving from the population screening, where is everyone the same, even the age, even the density. Now we move to screen according to risk. And the question, the clinical question, is not for the clinicians, for the radiologists, for everyone from the patients, but in the meetings is who, when, and how, and which healthy women truly belong to a high-risk pathway, at what age should screening start, and should it start before population screening, and the imaging. Which imaging? MRI, mammography, DBT, ultrasound, or tailored combination. And why? Because the high-risk healthy woman is asymptomatic, but her future risk is not average, the most important. And the goal is earlier detection with the least unnecessary burden. So we go with first at risk, imaging the second, and the interval and modality the third one. And the role of imaging screening is just to convert the information into a clear screening plan and with a practical pathway. So where does this talk, my talk, fits to this session is just over the previous talks, the other parts of the high-risk pathway. It was the pathology findings, we talk about them, the mutation, the genetic risk, the surgical risk reduction, have already, and the chemoprevention. And my talk is focused on screening imaging pathway with the modality, the staging age, and the interval. The multidisciplinary team is not only the genetics or the others, but the surgeons, the clinicians, even the personal doctors, defines the risk. And the radiologist helps translate into an imaging pathway. So I will speak about 5 groups, but they have some groups, subgroups, in order for the management. And to mention that is not one group. There are several pathways even in the group, in the 5 categories. The most important is hereditary, genetic high risk, is the pathogenic variants, the BRCA1, 2, PALB2, TP53, and more, or the calculated lifetime risk to be more than 20% or even 25%. And the other one, which is more important again, is the strong familial risk. The negative genes test is not an average risk. And we have the cases, they will talk about this, the prior chest irradiation, the screening starts earlier than the average risk screening, and the high risk pathology findings with the LCIS, NDH, and LH, they are already talked about it, the formal risk assessment actually, and the counseling. And we have the dense breast. The dense breast is not hereditary high risk, but it has low sensitivity risk and the masking effect. So the family history is a pattern, but it's not just one relative. It seems to be more concentrated and evaluation. How should the pathway be chosen? We need always evidence-based, guideline-supported, adapted to local practice. The evidence-based with the current data and outcome evidence, and the guidelines supported with the major recommendations like the American Cancer Society, the ACR, the USOPI, and even the directive of the European directive, which gives the final support and the final decisions actually. And the other thing that is very important is to adapt it to local practice in everywhere. What can be delivered safely and consistently. So the adapted to local practice includes the MRI access if there is availability of MRI, and if they have access to, for this reason, to do the MRI guided biopsy, because if you do the MRI and find something but there is not the ability to do the MRI guided biopsy, if it is not visible in everywhere, is not the case. And the genetic counseling colleague says a lot about this. And the MTT support for everyone, all the specialties, the reimbursement in everywhere. If there are no money, they cannot go to all these expensive examinations, and very important is the follow-up pathway. So a recommendation is useful only when a safe pathway exists behind it. They have already talked about the risk models, just to say that to use the right tool for the right question, like the GALE is 5 risk prevention discussion. The other one is to give 10-year lifetime. The other to give the risk about the family history, genetics, career probability, and the other one, the mutation, is the most useful. They use them more, and I want to concentrate to the last one, the imaging-based AI tools. It's imaging-based. What mean? They support risk stratification from mammographic data, is not routine replacement for validated models or guidelines, of course, but is much useful, and the future of AI is to be more promising. So the risk models support clinical judgment and guidelines, but they do not replace them. The point is not mathematics. It's but question for it to answer to replace with the other. Here is a practical framework based on major recommendations, all the things that I have already said, the risk-adapted screening pathways, and the one, the hereditary, which are the examples, and the pathway to be the MRI-centered pathway. This is the most important thing for my talk. To do the mammography and DBT, to add it later, of course, because of the radiation, and we start in younger ages, and to start and to have the annual and the intervals, the chest irradiation, thoracic at the young age, early surveillance, MRI and mammo and DBT, especially for this, and the age, if we know the age, or 8 years late, in the young age, or 8 years after the radiation, the radiotherapy. And about the familial risk, it's okay, we have the gene negative, but strong pattern. So we have the family history model, then the pathway, and the risk base. It's not just the first one. Everyone is just to do annually MRI. It's not this the case. It's just a lot of things to have in mind and decide when to do an MRI or the other things. And the same and less the high-risk pathology findings, LCIS, NDH, LH, is the formal risk again. And here we have the individual decisions about the screening. And the dense breast is risk and masking is with the others. If we have dense breast with the others, and is supplemental screening in selected women, and it is again personalized. I have to say about dense breast that even in the popular screening, in the population screening, the most of the countries have with the virus, the D and C, they have the supplementary, complementary, in addition, the ultrasound and the polyparametric. So by this, the framework is based on recommendations, and the final pathway depends on risk category, guidelines, MDT, and to have the local practice. So just quickly by this, the typical starting ages. So the guideline-dependent examples on high-risk screen, and these are the practical anchors, not one-size-fits-all rules. The hereditary, again, is annual contrast-enhanced breast MRI. It's not abbreviated. It's a contrast-enhanced and the full protocol for this category. The hereditary genetic risk, it takes all the time and often starts around 25 to 30 years old. The mammography and DBT is usually added later, depending on age and risk type, But yes, it's not just to leave the mammography because of the microcalcifications in the tubular carcinoma. And about the prior chest irradiation, starts around 25 years and 8 years after radiotherapy. So age, modality, and interval must follow the risk pathway and be guided by evidence, recommendations, and local practice. The implementation depends on the guideline used, MRI access, biopsy pathways, and genetic counseling, rebracement, and MTT support. I just repeat this in the conclusion. And all the conclusion until now is models and tables guide the pathway and do not replace clinical context, no, whatever. So risk models classify risk, they do not replace precise imaging alone, and the table is a framework, it supports, but does not replace guideline-based precise. So the final screening pathways is these 6 things: risk category, the age, the breast density, family genetic information, the guideline recommendations, and local practice. And the risk first, always, then modality, starting age, and interval. I am not repeat again, just we know about all talk about the BRCA1, 2, all this. Why MRI? Because it has the highest sensitivity, especially in young, dense breast. And when? Often 25 to 30 years, exact age in guidelines dependent, but why? If we don't have, and when we do this annual MRI, central imaging pathway with the mammography added later, and ultrasound is important not to be and to replace with this. It's supplementary. It's when we don't have the others, and always, of course, the ultrasound to be polyparametric with the density and the color Doppler and elastography and all the key with the ultrasound that we know it cannot replace the MRI. If MRI screening is offered, the pathway must include follow-up and biopsy access over the findings. Strong familial risk, gene negative. A negative genetic does not always mean average risk. So it is very important. The clinical pattern, is just the several affected relatives to be young age at diagnostics, the family history, the bilateral breast cancer, ovarian cancer history, and the risk assessment, use a family history based risk model instead of impression alone, not alone, and the screening implication, the lifetime risk if it is more than 20% MRI-based screening. Avoid both mistakes. Under screening when remains high, and the over screening when calculated risk is below the threshold. So it's not everything in a road. Prior to chest irradiation at a young age, we know who is the chest irradiation, most of the lymphoma, why I'm finishing, is just the conclusion. The future breast risk may appear years later, and the pathway, and the key point to have the previous treatment history may define today's screen risk, and the practical pathway is the annual MRI, often with mammography DBT, according to age and local guideline. This we have already said about this. The biopsy result is the most important, and to be sure that we have the biopsy result, it is, and the formal risk assessment, the screening pathway. So the same lesion is not the same screen protocol. MRI is considered when total calculated risk reaches the high risk threshold. And here with the dense breast, we all know that we have the 4 categories. Always by the screening we write the BIRATs, so the almost entire fatty we don't care, the scattered fibromuscular okay, but especially for the last, the extremely dense, So we have increasing density, masking effect, and reduced mammography sensitivity. The MRI, I have already said, the mammography DBT, about the calcifications for DCIS, the ultrasound we have already said, and the other one, which is now in the, what is the contrast mammography and the abbreviated MRI. There are many researchers in just replacing the standard MRI. It's a promising option in select setting, and the modality must follow all the guidelines. Why MRI matters? We have the higher sensitivity, particularly useful in younger, detects earlier the cancer, and all the others we have already said. And what are the future directions? Today we have the risk-adapted screening pathways, the evolving tools, the AI, the SEM, abbreviated MRI, radiomics, selected breast CT, the 3D CT, and the ductal evaluation they have already have in the talks. And the future is the prediction, prognostic satisfaction, stratification. So AI in screening. Now we have, actually yesterday, 8th of May, we have the European Commission, they sent us that the Joint Research Committee has just doing the review. So very soon it's going to be the guidelines. The AI in breast screening is now under the guidelines, just the review at the end. But we say that we must support it by the guidelines. And the radiomics imaging biomarkers is a quantitative features extracted from images, promising for predictions, prognosis, and treatment response, and not routine high-risk screening today. It's promising, all of them. And the risk is just all this, the risk information, the formal risk assessment, the risk group, all the imaging pathway, and the age and intervals. We must not forget not the age, to have the intervals and follow up. So the guideline-based, evidence-based, feasible locally, and documented reason of the pathway. The practical goal is not to create a new protocol for every woman, not the personal, is not like this, but to apply the appropriate risk-adapted pathway clearly and consistently. What can go wrong in practice is the underscreening, the negative genetic, and it's not only the imaging, it's the negative genetic, and the overscreening, and the wrong substitution. So not to believe that we do ultrasound in high risk and we are okay because we make the follow-up with ultrasound only. So all these are the common pitfalls in high risk screening. The danger is not only closing the wrong modality, it's assigning the wrong risk category, and connecting to this, the risk assessment. Yes, is the last. The risk information, documented risk category, imaging pathway, to recognize when screening is not average risk, to check them if they are okay, to apply the guidelines, and to assure density reporting for the radiologists, this one, second look ultrasound, MRI guided biopsy pathway, and MDT local practice. And to take the home messages is high risk women are not one homogeneous group. Risk first, then modality, starting age and interval. MRI is central in true high risk screening. Dense breast matter because of risk and masking. And future tools are promising, but implementation must remain evidence-based. The final message, the modality should follow the risk category, not the other way around. Thank you.
Thank you, Professor. Now it's my personal pleasure to introduce Professor Bahadir Goluglu, who I'm honored to call my friend. Besides being an amazing surgeon and academic, Professor Goluglu is one of the most hard-working persons who strives hard for the profession and for the training of the trainees.
Thank you so much. Thank you very much, dear chairs. It's a privilege for me to be here. I'm just replacing Professor Necip Gatchan because he has the excuse because of this, situation all over the world, especially this region. So I just replacing him and try to be very short and brief to give some messages about one of the options that you may give to your healthy woman, not patients, within high risk. So in my talk, I'll be mostly concentrating on 2-3 modalities, because the previous speakers already mentioned about, because we have 3 options, 3 modalities. One is, of course, the surgery, and that's a different topic, and mostly utilized option, of course. And also, if the patient or the woman would not accept those options, the chemo prevention or the surgical prevention, of course, the third option is always the close follow-up or the surveillance of those healthy women. So our concentration here is not cancer patients. These are healthy women. So we have many risk factors, and the difficulty here is to how to group them, how to categorize them, because when you put them into one basket, it's not practical use. So what we do, we use some tools, and these tools are considering some risk factors, such as hormonal features of the patient, plus some biopsy features, a previous biopsy with atypical ductal hyperplasia or lobular carcinoma in situ. And also there, as I said, some tools which are incorporating all those together to give you a score. Like there is a Gale risk or IBIS risk, like, if the IBIS risk is in 10 years is more than 5%, or the Gale risk in 5 years is more than 3%, so we regard them with high risk. So another issue here is that, which is a little bit more, challenging, is to deal with those women with a gene mutation. So far, we have only data, which is also very rare, of course, on those women with BRCA1 or 2 mutations. So what about the rest? So what we will do, we will contemplate the data that we get from those women who already had the BRCA1 or 2 mutation, because we don't have any data for the rest of them, like a PTEN mutation or PALB2 mutation or CHEK2 mutation or ATM mutation, which are the most common mutations in breast cancer. So the primary prevention, as I said, are 2 modalities. The one is surgical, so it's not our topic. The second one is the chemo prevention. So what we target with chemo prevention is the hormonal pathways. So this is the critical point. So there are, as I said, 4 tools, which I mentioned already, is the Gale and the IBIS, which is Tyrer-Cuzick model. Also, we have the BSC SC calculators, and the BRCA Pro, which is one of the oldest ones. So these are used to categorize these patients into low, intermediate, or high risk. So the first agent that we're using in chemoprevention is the selective estrogen receptor modulators since 1998, because the first trial that was published in 1998 was the NSABP1, Prevention 1 trial, with nearly 13,000 women. But we also had 3 more studies studying the role of tamoxifen in decreasing the risk in these patients. The other one is IBIS-1, Royal Marsden, and the Italian prevention trial. In all those trials, they show that using tamoxifen 20 milligrams for 5 years is providing a risk reduction nearly 50% in the whole cohort. But when you look deeply into these trials, the only effect that they saw is in the decrease in the risk in ER-positive cancer patients. And that's understandable, because you're targeting the hormonal pathways here. So what about the ER-negative tumors? We don't have anything to do in these, but you don't know whether the patient will have a ER2 negative tumor or ER-positive cancer. So that is why if you find a patient or a woman with a high risk, it is one of the ways that you can use in 50% or 60% of the time, and 70% of the time sometimes. These are hormone-positive cancer patients. So, but there's an issue of the safety, because we know that, for example, tamoxifen can only be used in the not only to premenopausal, of course, in postmenopausal, but if you're using in the postmenopausal patients, there's a risk of some endometrial cancer or venous thromboembolism. and the cataracts as well. So with the tamoxifen, provided with these the complications, there's a new trend of using a low-dose tamoxifen. It is 5 milligram per day with a TAM-01 trial. Last year or the year before, they published the 10-year results of the follow-up, and they found that, again, with this low dose, even with 5 milligrams, there is a reduction of breast cancer 42% and 50% in the DCI's recurrence. And also, they have an effect on the contralateral breast recurrence, and this could be also put into your mind to use it even in breast cancer patients with a unilateral resection. But interestingly or expectedly, the complication rate is nil. That is 0. So this is why now we can consider using low-dose tamoxifen, which is in our protocol. Then in those patients with lobular carcinoma in situ or atypical ductal carcinoma, even with the hormone-sensitive DCIS patients, this is one of the options that you can use safely. So what about the postmenopausal woman? Yes, there is a way you can use tamoxifen, but we have also other selective estrogen receptor modulators, starting with the raloxifene, which is a second-generation SERM. And it was incidentally found that in the postmenopausal osteoporotic patients, when they started to use raloxifene, in a side effect, they found that there was a decrease in breast cancer development. And then they further did, after more trial, the core trial with extending 4 more years with 60 milligrams of raloxifene. And with the roof trial, as you can see, there are more than 20,000 women included in these trials. Again, they found that there's a decrease, nearly 40 to 65% of decrease in breast cancer development. But it's the same as that we saw in the tamoxifen trials. The main effect was seen in decreasing the hormone-positive breast cancer. But good side that there's no increase in endometrial cancer and there's no significant venous thromboembolism risk in these trials. And when you use it and you stop the drug, using the drug, the effect of these drugs continues for the coming 5 to 8 years. So it is still useful when they stop using it. So what about the difference between tamoxifen and raloxifene for the postmenopausal? This is the P2 trial published back in 2006, which is 20 years ago. And they found that 20,000 women were included in this. And they're similar in decreasing invasive breast cancer risk. And in raloxifene, they found a little bit more effect on non-invasive breast cancer risk. And raloxifene is better than in decreasing, it's as a side effect, of course, there is less endometrial cancer and also less thromboembolic events and also less cataracts. So after these trials and this comparison trial, and they started to recommend using raloxifene in these postmenopausal high-risk women. But the era changed after 2007. Because we now have aromatase inhibitors, and they are using the same pathway as well, to blocking the estrogen receptors, not the receptors in the hormonal pathway. And here we have 2 main trials. The first one is MAP3 trial using exemestane, 20 milligrams per day, and the other one is IBIS-2 trial. Remember, IBIS-1 trial, it was using tamoxifen, but here IBIS-2 trial, they use anastrozole. And again, they included nearly more than 4,000 women in the MAP3 trial and nearly 4,000 in the IBIS-2 trial. Again, in these trials, they found, again, the decreasing the breast cancer from 40 to 65% of the time, and the benefit is equal in all high-risk groups, but in the IBIS-2 trial, more specific to the ER-positive invasive cancers, they found that the pronounced effect was seen in this group of patients. So, for the side effects, there's no significant difference in fractures and cardiovascular events and the thromboembolism and the deaths. And again, they persist in the long-term follow-up. And arthritis, of course, it's unexpected. You know that in using, even in the cancer patients, we see more arthritis and the hot flashes in these drugs due to their mechanism, of course, with exemestane and anastrozole. So in general, when you compare all these together, to give a message to you, so when you have tamoxifen, raloxifene, and AI, it's a pooled result with exemestane and anastrozole. And here there is no study for letrozole, by the way, but I don't know if there's any contraindication for this because we don't have any study, but they have the same mechanism. So as you can see, the raloxifene and AI has the same risk reduction. And this reduction is more pronounced in ER-positive breast cancer patients than comparing to tamoxifen. And again, for the adverse events, endometrial cancer is definitely increased in tamoxifen, but no change in raloxifene and AI. And venous thromboembolism is also increased in tamoxifen, little bit increase in raloxifene, but in AI it's also safe. And for the cataracts, definitely tamoxifen is harmful. For the bone fractures, there's a decrease in all of the drugs, and hot flashes is more pronounced in AI, and arthralgia is, of course, naturally is very high in AI. So as you can see on this slide, it's in the postmenopausal patients, of course. For the premenopausal, there's only one way that you can do is a low-dose tamoxifen, but for the postmenopausal patients or the high-risk woman, it seems that using AI is more safe. So what about BRCA1 or 2 mutations, those ladies with this? It is, as I said, it's a very scarce data for this. And one study is just 2 studies for tamoxifen in the P1 subgroup. There's very few patients with the BRCA1 and BRCA2 carriers. And it seems that statistically there's a benefit by using tamoxifen, but it is very small sample. So we cannot contemplate any kind of result or a guide to use in our daily practice. Also for the contralateral breast cancer, yes, by using this after cancer, yes, there's a decrease in seeing secondary cancer in the contralateral breast by decreasing the risk by 50 to 60%. For the letrozole, there's one study with as you can see, 170 patients. There's no, again, a beneficial effect because, again, they found as underpowered because they only could include 170 patients. Again, with the AI, as we saw in tamoxifen, there's a risk reduction with using AI in those cancer patients. So the update and the barriers and future directions, the only thing here that it is easy theoretically to recommend any kind of an hormonal chemoprevention in these patients, on paper, of course. But in practice, I don't know if you have the same experience, only 16% of your high-risk patients are using these drugs. So this is not so much practical. If you're sure that your patients are using or the ladies are using, because these are not cancer patients, so this is some kind of what they understand what you're explaining. First, they are fear of side effects when you talk about this. The second is the lack of awareness and low risk perception. Okay, I already don't have any cancer, so I will not have it. So live it. I mean, this is a chance. So, and also, again, because there's not too many data for the BRCA patients, BRCA positive patients, they don't use it. So for future, there are 6 studies, the 6 agents that were just studied so far, like metformin, fenretidine, natural compounds like curcumin and quercetin, vitamin D supplementation, biophosphonates, and low-dose aspirin or antiplatelet. Only one of them had just some kind of a prospect for future, which had the retinoic acid derivative, which is fenretidine, is a phase 3 study. It was already completed. And also, they found the 40% of decrease in high risk after 15 years of follow-up. But it is not written in the guidelines to use it so far because of the safety reasons. So, in general, for those with the perimenopausal, but over 35 years, tamoxifen is the first line, but I think 5 milligrams should be the standard. So the key benefit is that this is the only approved option with the 50% of decrease in high risk. But there's a risk, of course, with the endometrial cancer and thromboembolism. For the postmenopausal patient with the low comorbidity, you can start with anastrozole or exemestane. They had the greatest efficacy compared to the other SERMs, raloxifene, but they have side effects like arthralgia and hot flashes. For the patients with the osteoporosis, so raloxifene could be the mainstay to start with. because they have a dual benefit. One is the breast cancer prevention, and second, to prevent the vertebral fracture, which is very important. There's a slight risk in the venous thromboembolism, but no benefit, remember that, for non-invasive breast cancer. For those with the risk of venous thromboembolism and endometrial cancer risk, start with anastrozole and exemestane. And for the BRCA2 carriers, because we don't know whether there's any effect for the BRCA1 carriers, and this is again understandable because we know that with the BRCA1 mutation, you see triple negative cancers more, or hormone negative cancers. But with the BRCA2 carriers, they have more hormone positive cancers. And here, you can start with an AI or secondly, tamoxifen. So the key takeaways from my presentation here: chemoprevention with tamoxifen, raloxifene, or AI significantly reduces breast cancer incidence anyway, primarily in hormone-positive high-risk women, in tumors which can be seen in high-risk women. The AIs offer superior efficacy for postmenopausal women with a better safety profile. And the low-dose tamoxifen achieves a comparable efficacy to 20 milligrams of tamoxifen with a more safe profile, with fewer adverse events, and is a promising strategy. And evidence for chemoprevention BRCA1 or 2 carriers is limited and inconclusive, so tamoxifen and AI reduces the contralateral risk in those with the cancer, so you may maybe use it only for the BRCA2s, but we don't have anything to do with the BRCA1s, so the surgery would be the only option in these patients, or follow-up with radiology. And uptake remains critically low, like I said, 16%, but in some studies it's as low as 9%. And addressing the side effect concerns, improving patient education, and providing personalized risk-benefit counseling, then we may increase their use these drugs. And the future directions like denosumab or combination strategies and other retinoic acids and transdermal delivery of those drugs may optimize the both efficacy and tolerability for future. Thank you very much.
Thank you, Professor. Our last speaker is Dr. Ümit Uğurlu. His presentation is risk counseling for high-risk men.
So thank you very much. Thank you very much to the organizers to giving me this topic. This is a hard topic since the evidence is inconclusive for this topic, and most of the data is extrapolated from the women's trials. So I have an audience poll. Could you use your phones and scan the barcode, please, if you can do it? So the definition of high-risk men for breast cancer is not very clear, so I want to hear your definition about these high-risk men. Okay. You can select multiple choices. Only one part, 3, okay. So please rank them, okay. Actually, as I told you, the definition of high-risk man is not clear in the literature, but we can see that we have a consensus on the BRCA1/2 pathologic variant carriers and the history of chest radiation therapy, and someone voted for the gynecomastia and the cirrhosis, and also Klinefelter syndrome. Okay, I think the winner is the BRCA1/2 mutation. So one ranking, yes. So the winner is the BRCA1/2 mutation. Anyway, we all know that the high-risk group is that group, the healthy man who has BRCA1/2 mutation. So we call them the real high-risk group. But on the literature, there are some groups that we underestimate. These are the all elderly men. We can't call them the high-risk group, but these are the risky groups with Klinefelter syndrome or the cirrhosis. And also, if they have any history of chest radiation, we know that these men are under risk to develop breast cancer. And we have another underestimated group. These are the transgender women that since they are under chronic estrogen treatment, they have 5 times more probability of having breast cancer in the future. So this is the real group, and these are the other groups, the risk groups that are being discussed in the literature. So we must understand the male breast cancer. Since we do not have too much data or evidence about this, but this is a European trial, and it's actually done in the 93 centers from 9 countries. We can see that only 20% of these cases has tested and have the BRCA1/2 mutation. Although only 20% had the BRCA1/2 mutation, you can see that the median age is 68.4 years. So this is a disease of the elderly. Even though they have BRCA2 mutation, they develop breast cancer in these elderly ages. We have some recommendations on the literature, counter-based recommendations to have hereditary gene testing in men. These are the well-known group, but according to these, this is the British NHS recommendation. If a healthy man has a first-degree relative with a breast and ovarian cancer, plus if he has a CAN risk over 10, you can ask for a genetic consultation. CAN risk is Cambridge-based web tool. It's free, and you enter some data here. And if the risk is over 10%, plus if the healthy man has a first-degree relative with a breast and ovarian cancer, you can ask for a genetic consultation and also the hereditary gene panel testing. NCCN does not take the CAN risk into consideration, since the CAN risk is a web tool developed from Britain. They recommend genetic testing with the familial, to men with the familial BRCA1/2 mutations. And also we have some risk groups like prostate cancer with some high-risk categories and pancreas cancer patients. You can just ask for hereditary gene panel testing according to the NCCN group. So which mutations cause male breast cancer? So there's not a huge data about these male breast cancer. These are the data, these are case series from some centers. You can see that BRCA2 mutation constitutes 15% of the mutation. So man with BRCA1 mutation has 4.5% probability to have breast cancer, but mostly the male breast cancer patients have BRCA2 mutations. And we all know that only 20% of male breast cancer patients has family history of breast cancer. So how serious is it? So in contrast to women, you can see that the general male population risk is very low for developing male breast cancer. If you have a BRCA2 mutation, it's up to 9%. So this is the lifelong population risk. It's around 8% to develop breast cancer in his lifetime. So it's not high as we see in women. But in prostate cancer, you can see that the risk increases, and also in pancreatic cancer, the risk is increasing. But the most risky group is prostate cancer plus the BRCA2 mutation. So according to the NCCN guidelines, the recommendation for the surveillance of these male BRCA2 carriers is, they say that there is 8% lifetime risk, breast cancer risk. So there is a recommendation of mammography or ultrasound in healthy men who carry BRCA2 mutation and at age 50 start to make mammographic screening. Plus, if they have gynecomastia and Klinefelter syndrome, you can see that their relative risk increases. Without the BRCA2 mutation, we know that gynecomastia does not increase breast cancer, but if there is plus gynecomastia with the BRCA2 mutation, you have to be strictly recommending these men to have mammography recommendation. But for the other group, there is the statement called consider mammography, so you can consider mammography in the other group. The important thing is you have to ask for prostate-specific antigen starting from 40 and your cutoff is 3. If the value increases up to 5, 7, 6, 8, something like that, you must consider some kind of urological consultation. These are the results of this famous IMPACT study. So if a man has BRCA2 mutation starting from age 40, you have to ask for annual PSA screening. This is a strong recommendation in the NCCN guidelines. So about pancreas, we all know that there is no recommendation for BRCA2 carrier men. Age 50, you can ask for yearly MRIs plus endoscopic ultrasound according to your facility. But if they have first or second degree relative with a pancreatic cancer. But if they have STK11 pathologic mutation, please start the pancreatic protocols like MRI screening and ultrasound screening starting from 35. Otherwise, there is no strong recommendation. If they have a family history with the BRCA2 mutation, plus if they are 50 years old, you can start MRI screening with abdominal MRI plus endoscopic ultrasound. Australian guidelines do not recommend, like the other guidelines, any surgical prophylactic mastectomy or risk-reducing medication. But for the Syrians, they do not take gynecomastia or the Klinefelter syndrome into consideration. They say that consider mammography, annual mammography, starting from age 50 if you have a diagnosis of pathological BRCA1 or 2 mutation. So is it worth it to screen men with the mammography? Actually, this is a beautiful trial from the MD Anderson. There are 163 men. They have the high-risk profile, and 15% have the BRCA2 mutation. And you can see that the detection rate is very similar to women. So actually, it's worth it. So if you do mammography screening in the BRCA2 mutant patients, also in the high-risk groups, you can see that you can detect 5 cancers in 1,000 healthy males. So the results are similar to the female groups. The problem is adherence to the screening mammography in men, because the man's awareness about the breast cancer is not same as women. You can see that according to this trial, females go to the screening if they have a BRCA2 or 1 mutation, more than 98%, but the adherence in men to the mammography is quite low. They are against mammography, or they do not want to get mammography screening annually, but their adherence to the clinical breast examination is quite high. The problem is with the chemoprophylaxis. The previous speakers talk about chemoprophylaxis with different drugs. In the last ACBRS Congress in 2025, there is a section about the chemoprophylaxis plus treatment of male breast cancer. They say that we have to understand the man's estrogen mechanism differently from the female. We know that man has 80% of estrogen conversion from peripherally, and they have 20% from testicular secretion. But you cannot extrapolate the data from female because aromatase inhibitors do not work or do not decrease the estrogen like they do in women. It's a very new evidence since they did not publish this, but they say that when you prescribe aromatase inhibitors to men, they first increase the LH and the FSH, then they increase testosterone, but they also increase estrogen, so they do not suppress any estrogen levels. So, and you cannot suppress the testicular estrogen secretion by aromatase inhibitors. Since there is no recommendation for chemoprevention with tamoxifen or aromatase inhibitors, you cannot consider aromatase inhibitors if your MDT has a decision to give any chemoprophylaxis or treatment in men. They don't work, but you can do it with tamoxifen, but we have problems with the duration and the dosage of the tamoxifen to be used in healthy BRCA2 mutant men with for chemoprophylaxis. So this is our data. We have 32 male breast cancers who are tested for BRCA for the hereditary gene panel testing, and we saw that most of these men had BRCA2 mutations, and some has RAD51D and BRCA1 mutation. And among the females and the males relatives, we have now 8 men who has the diagnosis of BRCA2 pathological variants. They are total healthy men between the 22 to 51 years old. The median age is 34. Diagnosing pathological variant is a trouble, I think, because when you make a diagnosis of BRCA2 mutation in a man, we do not have strong recommendations in the guidelines. So among these 8 individuals, 7 is under follow-up now. One of them went to bilateral mastectomy with his desire because his father and his elderly brother died from male breast cancer. So he's undergone bilateral mastectomy. I know there is no recommendation, but it was his desire. Now we do follow-up for this 7 men with clinical breast examination every 6 months. We started mammography screening starting from 50, and we measure the prostate-specific antigen starting at 40. And this is a very new data. We know that if the man has a BRCA2 mutation, and if there is Helicobacter pylori infection in stomach, there is 5 times more risk to get stomach cancer. So we always do upper GI endoscopy and eradicate the H. pylori infection in men with these BRCA2 mutations. So thank you very much for your attention.
Thank you, Professor, for this excellent talk. I'd like to ask if there are any questions or comments from the floor.
I would like to add some additive information about atypic lobular hyperplasia that I didn't see on the slides. For the atypic lobular hyperplasia that is found after corneal biopsy in a calcification, and if we are sure that we have removed all the calcifications and there is no any calcification back, so to make follow-up is enough. But if there is a mass, let's think that we did corneal biopsy and the diagnosis atypical lobular hyperplasia. But if there is a mass or a distortion, a speculate lesion, or a macrocalcification left, or the patient is a young age or having a history of breast cancer, or if the corneal biopsy specimen samples are lower than 12, I mean low volume samples, we should do research, we should do surgery and remove the lesion. Corneal biopsy revealing atypic lobular hyperplasia is not enough. This is not a premalign lesion, but in these cases that I mentioned, there may be upgrade to malignity. We are not sure if the lesion back is atypic lobular hyperplasia or invasive lobular cancer. So we should remove the lesion, even the calcification or the mass.
Thank you for that comment. I think the issue is still, I think there's no real doubt that we need to excise the lesion. Then there was the question of whether we need to remove the lesion with margins, and we agree that we don't need to remove the lesion with margins, but I think excision is usually still indicated. I have a question to the colleagues about any possible use of AI tools to combine risk models, genetic testing, and breast density to come out with a value to suggest screening? Have everyone been using a particular AI tool to guide risk-stratified screening? So apparently not. Any other comments, please? Professor?
So thank you very much for excellent talks. I would like to ask a question about a high-risk patient and use of HRTs. For example, would you recommend using HRT in a high-risk person, or would you recommend, the tamoxifen plus HRT in the same women? So do you know any use about it? Do you have any experience?
Professor is going to answer this question.
So, for example, your intelligent patients who knows everything and everybody. So, and then she comes to you, and then she tells you, okay, I'm suffering from the tamoxifen side effects, and she has an ADH, and she wants to use HRT as well at the age of 60. So, what would you recommend to that patient?
It's not only my recommendation, it's national recommendations, international. I mean, in reproductive age women, no contraceptive pills. In postmenopausal women, no HRT, and no combination with tamoxifen with HRT. No, the answer is simple words. No, no, no.
Okay, thank you very much. Can I have another question for Professor Yararbaş?
Yes, please.
So he is one of the best medical geneticists in Turkey, and I would like to thank him for the excellent talk. And I would like to ask him about the scorings, like Kuzik models or other models. So how good is it to extrapolate those data, which was based on the Western population, but not Turkish population? So how confident you are using that data in Turkish patients? And do we have, my second question, where are we starting on our own database for genetic the diseases? Thank you very much. Yes, Turkish population. Yes, thank you very much.
Turkish Genome Project is ongoing, still ongoing, and we are receiving data. But for polygenic risk scores, Turkish population suits well for the European population, and European population is a well-studied population. So polygenic risk scores apply for precision diagnostic tool, but in the future, of course, and as supportive tool, of course. And the other part, they are not AI integrated tools. They only make some implementations for risk models. They are not like the polygenic risk score. They do not need any population-based data. And they are not must be implemented. For example, if they give a 3% risk, does that mean that if we collect that 3% risk carrying 100 women, will 3 of them will develop breast cancer in 10 years? They are not like the oncotype testing or other genetic-based testing. So what about the other 100? So we might find 100 patients and they will not develop. So we cannot implement for population-based risk modeling these AI tools, but maybe the AI tools were asked previously. All these data may be combined together with AI tools. For example, the technology is developing radiogenomic tools or genoradiomic tools, combining the radiological features with, for example, possibly carrying targetable, actionable first-tier mutations like EGFR mutation, for example, for lung masses. And some tools like Sophia Genetics, DDM, combines population data, clinical data, genetic data, radiological data, and supports a clinical decision-making tool. But all these are not one by one really realistic for now.
Yes, please.
The probability of, as far as I know, cancer development after negative colonoscopy within 5 years is almost zero. But I don't know, does a negative MRI guarantee 1 year for high-risk patients?
Thank you for the question. It's just the imaging tool is the one by the others. You mean it has all the BRCA1 or 2, so it's very risk? It depends for many things because it's annually. So you mean to have more interval, but the negative, if it belongs the imager, the radiologist to do it properly. I said before that there are two kinds of MRI. The abbreviated MRI, which is a short protocol, even with contrast or not, and the other one. So the only possibility to be negative, but there is disease, is not to be the proper protocol and the proper result. The radiologist who gives the report. There are not any just to do annually and find that it was occult and we didn't see it. You mean that it will be the interval to be until now? These are the guidelines, but perhaps yes.
Okay, I have a comment about the semantics of the use of lobular carcinoma in situ against lobular neoplasia. I'm not sure what your practice is in more recent practice. And the other comment is maybe more theoretical, is what makes a high-risk patient high-risk? We know that a genetic mutation gives you an oncogenetic problem, but why does a person with LCIS makes it at high risk? Is it something wrong with the breast? Is it something wrong with the hormones? Is it something wrong with something else? Is it something wrong with her oncogenicity? I'm not sure if anyone can answer my question. Why these high-risk patients are still high risk, even if we remove the lesion, and they are high risk for both breasts, not for the index breast only.
I mean, so I think we can only do some speculations about it.
Yes, that's it.
So, for example, in ADH patients, so this definition of ADH just 2 millimeter or smaller than 2 millimeter of the cells. If the cell is 2.5, it is low-grade DCIS. So it is very, very thin, I think, the borders between, the high risk and the cancer.
But
Maybe
then
that's
can we
why.
say that a person with DCIS has definitely necessarily increased the risk of cancer on the other breast, for example?
But
unlike a person with lobular neoplasia, who does have an increased risk?
Yeah, so there's no answer for that in me at least. So may I have another question, please?
Yes, please.
So first of all, I would like to thank Professor Uğurlu for his excellent presentation. So I would like to ask you, first of all, thank you for your excellent presentation. You summarized the world data, and at the end you gave your own data at the end of your, I think it was excellent. Thank you very much. And something I didn't understand. So shall we do screening all BRCA2 men after the age of 50, or the men after the age of 50, BRCA positive men with gynecomastia or Klinefelter syndrome? So I didn't understand, I'm sorry.
Thank you. So there is no strong evidence about this question. Thank you very much for the question. But according to the guidelines, they say that there is a recommendation for BRCA2 men with gynecomastia or Klinefelter syndrome, just do the screening starting from 50. Without gynecomastia or Klinefelter syndrome, you can consider it. Just there is no strong recommendation.
But if there is presence of gynecomastia,
yes, they say that do it because their relative risk is around 76 point something.
Okay,
so
thank you.
Their relative risk increases. But if they have these two problems, they strongly recommend it.
Okay.
But without these problems, just consider it.
Okay, thank you very much. Thank you.
Thank you all for your, I think we have one last comment already. Okay, so we'll leave it for lunch. We'll discuss this, your comment for lunch. We're going to stop this session and we'll meet after the lunch break. Thank you.
Some blood glucose.